Greetings from Indian Journal of Anaesthesia. I, Dr. Reniki Sharma, will be presenting an article published in the July 2024 issue of IJA titled Comparison of Intrathecal Morphine versus erector spinae block in patients for postoperative analgesia in patients with end-stage kidney disease undergoing kidney transplantation, a randomized clinical study. Effective postoperative pain management is crucial for enhanced recovery after kidney transplantation, as inadequate pain control can lead to complications. Use of regional anesthesia techniques results in reduced need for IV analgesics and opioids, with fewer adverse effects and improves recovery. These techniques include intrathecal morphine, epidural analgesia, surgical site infiltration of local anesthetics, and facial plane blocks. In kidney transplant patients, recent studies have evaluated intrathecal morphine in erector spinae plane block for postoperative analgesia in kidney transplant patients, finding them both to be effective. But no study have compared their analgesic quality, duration, and related adverse effect. Hence, this study aimed to assess the analgesic efficacy of erector spinae plane block as compared to intrathecal morphine. So the primary objective was to compare the quality of postoperative analgesia as measured by numerical rating scale over 24 hours in patients undergoing kidney transplant surgeries receiving either the erector spinae plane block or the intrathecal morphine. Secondary outcomes were duration of analgesia, fentanyl consumption, rescue analgesic needs, catheter-related bladder discomfort, and any complications related to procedures or drugs used in between the two groups. So institution ethical committee approval was taken and the trial was registered in Clinical Trial Registry of India. It was a randomized controlled trial with patients from 20 to 60 years of age with end-stage kidney disease for kidney transplant surgery. Exclusion criteria were patient refusal, allergy to study drugs, contraindication to subarachnoid or peripheral nerve block, like bleeding diathesis, infections, neurological dysfunctions, history of drug abuse, recent use of psychoactive drugs or analgesics, and incomprehensiveness to use patient control analgesia device. Randomization was done using computer-generated random number table and allocation concealment was done using a sequentially numbered opaque silk envelope, which was kept with a non-participating nurse. The patients were allocated into two groups. Group M received 200 microgram of preservative-free intrathecal morphine and Group E received 20 ml of 0.5% ropivacaine in erector spinae plane block. The block was given by an independent experienced anesthetist not further involved in the study. The outcome assessors were blinded to the study procedure. Pre-anesthetic checkup done on the previous day explained the patient on the use of patient control analgesia device and the NRS scores. On the day of surgery, 2 hours before shifting the patients, all patients received palonocetrone, alprazolam, and immunosuppressant drugs. So before induction, the patients were randomized into two groups. The group M received 200 microgram of preservative-free intrathecal morphine, 0.2 ml, with 1.8 ml of normal saline. A total of 2 ml was given in the L3, L4 or L4, L5 space in the sitting position with a 25 gauge spinal needle. The patients allotted to group E received ultrasound-guided erector spinae plane block at the T10 level under aseptic precautions in the lateral position with a 10 centimeter 22 gauge needle and a drug of 20 ml of 0.5% ropivacaine was given. All patients were induced with midazolam, fentanyl, propofol, and cisatracurium, and they were intubated using an endotracheal tube. After extubation, the fentanyl IV patient control analgesia pump was attached with no baseline infusion. 10 mics per ml of bolus dose was given with a lockout interval of 10 minutes, and it was set such that the maximum allowed doses per hour were 4. If the NRS score was more than equal to 4, Even after the fentanyl IV patient control analgesia pump, IV PCM 500 milligram was used as a rescue analgesic, which did not exceed more than 2 gram in 24 hours. The catheter-related bladder dysfunction scoring was done, where if there was no discomfort, then it was given a score of 0. If there was only mild discomfort upon questioning, it was given a score of 1. Moderate discomfort with an urge to pass urine without questioning was given a score of 2, and severe discomfort with urge to pass urine with behavioral changes such as pulling on the catheter was given a score of 3. If there was depression in respiration with a respiratory rate of less than 10 per minute, supplemental oxygen was given or IV naloxone was given if required. In case of postoperative nausea, vomiting, 4 milligram IV ondansetron was given. In case the patient developed pruritus, dexamethasone 8 milligram IV was given. So the primary outcome was NRS from 0 to 10 at the immediate postoperative period at 1 hour, 3 hours, 6 hours, 12 hours, 18 and 24 hours after the patient was shifted to the postoperative ward for both static, that is at rest pain, and dynamic pain, that is pain on coughing. The secondary outcomes were time to first analgesia request, total fentanyl consumption in 24 hours postoperatively, and complications like opioid-related side effects, catheter-related bladder dysfunction, respiratory depression, etc. in between the two groups. So based on the author's experience, by anticipating a relatively large effect size of 0.74 in NRS between both the groups, the final sample size was calculated to be 60 at 5% level of significance and 80% power. So 30 patients per group. SPSS version 24 was used for analysis. The descriptive statistics were shown as proportions of percentages for categorical variables. Mean and standard deviation was used for continuous variables. Fisher's exact test or the chi-square test was used to compare proportions like gender complications. All the continuous variables were analyzed using Mann-Whitney test or the student t-test. Wilcoxon sign ranked or paired t-test were used based on the normality of the data. A p-value of less than 0.05 was considered significant. So in results, this is a conserved diagram. The 71 patients were assessed for eligibility, out of which 11 were excluded as they did not meet the inclusion criteria. 60 patients were randomized ultimately, and 30 patients per group were allocated in the group intrathecal morphine and the group that received erector spinae block. And ultimately, all these patients were analyzed. So in this table, we can see that the baseline characteristics did not differ between the two groups. The duration of surgery, duration of anesthesia did not differ between the two groups. In primary objective, the static NRS, that is the NRS at rest, at immediate postoperative period, 1 hour, 3 hours, 6 hours, 12 hours, 18 hours, and 24 hours was significantly lower with the group receiving intrathecal morphine. But the NRS of the group receiving the erector spinae plane block was also less than 4 in almost all the patients. In case of dynamic NRS, that is the NRS for coughing, it was seen that at all time points, the NRS was significantly lower in the group receiving intrathecal morphine, whereas at 24 hours, the NRS did not differ significantly between the two groups. In secondary objective, the time to first analgesia request were significantly higher in the patients receiving intrathecal morphine. The total fentanyl consumption and total rescue analgesia consumption did not differ between the two groups. Again, when we look at this table showing the catheter-related bladder dysfunction trends between the intrathecal morphine group and the erector spinae plane group, we can see that the intrathecal morphine group had lower CRBD scores than the group receiving erector spinae plane block at all time points. The postoperative nausea vomiting was significantly higher in the group receiving intrathecal morphine. Respiratory depression did not differ between the two groups, but the incidence of pruritus was again significantly higher in patients receiving intrathecal morphine. Thus, from the study, it can be seen that there was no significant difference in the quality and duration of postoperative analgesia between the two groups. Both groups experienced a significant reduction in the postoperative NRS scores up to 24 hours, aligning with other studies that found intrathecal morphine to be effective in reducing postoperative pain. But these studies used a higher dose of morphine. Here we used, the authors used 200 microgram of intrathecal morphine, but in these studies, it was seen that around 400 microgram of intrathecal morphine was used. The mean time to the first analgesic request was significantly longer in the intrathecal morphine group compared to the erector spinae group, indicating a reduced need for rescue analgesics. While postoperative fentanyl consumption was higher in the erector spinae plane group, it was not statistically significant, probably because the intrathecal morphine dose was also lower than compared to other studies in this study. Other studies have also noted higher opioid consumption with the erector spinae plane group compared to intrathecal morphine, which can again depending on the amount of morphine used. There was a decreased requirement for rescue analgesics and significant reduction in the catheter-related bladder dysfunction incidence up to 24 hours in the intrathecal morphine group. Similar results have been found in other surgeries also. The patients in the erector spinae plane group experienced fewer instances of nausea, vomiting, and pruritus compared to the intrathecal morphine group. The limitations of this study include a small sample size, a male prevalent study population, and the absence of a control group due to ethical considerations. Thus, from this study, it can be concluded that intrathecal morphine provides long-lasting postoperative analgesia at the cost of higher side effects like pruritus and nausea vomiting than erector spinae plane block in patients undergoing surgery for kidney transplantation. Future research could explore modified techniques like continuous catheters or adjuvant agents in the erector spinae plane blocks to enhance postoperative management. Thank you.